It is my pleasure to introduce our speaker, Dr. Alyasah A. Sewell, who graduated with a PhD in population studies from the University of Pennsylvania. Dr. Sewell is a sociologist and of considerable distinction, now is associate professor of sociology at Emory University, and was founder and director of the Race and Policing Project. Dr. Sewell has been studying the political economy of race, neighborhoods, and health, has received support from the NIH, the Ford Foundation, the NSF, and the Baden-Württemberg Foundation, among others, and has been designated by Planned Parenthood as the future innovator and visionary who will transform Black communities. The topic is obviously extraordinarily timely, as they would say, ripped from the headlines of central contemporary issues in America. So we're all looking forward to this presentation with great anticipation. Thank you for joining us.
Hey, how are y'all doing? It's great to be here. I'll run something back on you. I have my PhD from Indiana University, Bloomington, Department of Sociology, but I did a postdoc at the Population Studies Center in University of Pennsylvania for quite some time, actually, and loved my time there. But
okay, I didn't quite get it right. Sorry about my dyslexia.
Okay, so I'm like, this is recorded. I got to make sure my alma maters are actually said properly. I don't want to be lambasted at some point of time for my own people. So it's not you, but it's for not to shame my own people. But it's great to be here. Unfortunately, this is a conversation for the times. I didn't, write this for the times, unfortunately, but it is where we are right now. So I'm going to get into this. It's called I'm going to share my screen. Is that okay?
Absolutely.
Right, awesome. Should be able to pick. Here we go. I'm going to share with you what now is a body of research around the feedbacks between systemic violence and health, operating through an institution of surveillance. We think, but there was a paper that I recently pulled out. It focuses, we'll get to the end of it, but I did pull up this idea of negative illness feedbacks, which again is not a function of one work or one thing. This is, a couple of different studies, 5 to 7 studies we're pulling together to kind of come to this conclusion. But essentially, we're looking at the health consequences of police violence and considering this idea that, police violence, police brutality is both a public health, event. It is something we should be paying to as public health researchers, but it is itself a public health problem. It's a public health problem. It's actually an indicator of injury itself. So we can't think about these two things as, we're looking into this thing from a system perspective, but we have to think about what the system is running back for us. So that's where I'll kind of start today. So when we look at the kind of broader approach of public health to the police and the policing institution, when we first started considering this, we looked at police as first responders. So when there was some type of injury in the community, police would come in and they're the people on the scene to make sure that there's not continued injury, that the injury that is being enacted stops, and that we can essentially break this cycle. And then through that, we cycle people who are participating in injurious events into, places of essentially rehab. So we're always talking about healthcare when we're talking about police, but over time, particularly in the 90s, we've started to get a move to thinking about policing itself as a stressor. And here we're not talking about the police as a stressor, but the contact, the civilian contact that happens when a police engages someone, number one, either as a person of interest or as someone who, we're trying to stop behavior that's in the act, or when we're talking about walking down the street, right? So we have within the last, couple of, I would say 2 to 3 decades at this point in time, a kind of movement to proactive policing, aggressive policing, saying, hey, if we put police on the streets, it's going to deter crime. we actually know from the longer history of that it's actually not true. There is something about the actual social environment that's driving some of this. It's not just witnessing a broken window that's driving this. It's about the interaction of people with the places they're in and other people in those places. And the police are one of those people. And when you have this contact, this regular contact with the police, either, you know, a traumatic moment or, you know, maybe within the last month or last 30 days, it's likely that you're going to be harassed by the police and so on and so forth. It's now a stressful event, a stressful environment, right? It's a stress producer, right? We start calling these life events, and it starts to get into all these scales that we consider as formative for understanding health equity, health behaviors, and so on and so forth. In this model of understanding the stressors, there is a part of it says it doesn't have to be you that has been and had that contact with the police. It could simply be someone in your network. Someone you know. It could even be someone that someone else knows. So you start to have this essentially this radiation effect from the individual that's being stopped to the people around them, vicarious, and I call them indirect effects. And the approach that I take to understanding police violence is in this idea of indirect effects. You personally are not being stopped, but you're in the context of people who are stopped. And here, they're not even people who you may not even know them. Literally, they're not a neighbor. They're not someone from, you know, a couple streets over. They're someone walking through your neighborhood. Again, could be or could not be a neighbor, but there's someone who's using the geographical boundaries of your space. And in this place, we actually start to think about within the last 20 years, in particular, since about the early 21st century, actually thinking about police themselves as violence offenders, right? So they're part of the offense. They could go to jail as much of other people. And we do have these instances of very, very unequitable and unethical policing that, you know, you keep doing it too many times and you start to cross boundaries that you really shouldn't from any person's perspective. But mostly when we think about police violence, these are things that they're part of the everyday part of being a police, right? You have the part of being a police is you have the legal the permission to use violence in order to, or physical, you know, treatment in order to stop a crime, to curb the threat of people who are engaged in criminal behavior. Whether it's destruction of property or destruction of people, you can use force. We've given the police more and more latitude across time. The first kind of case that started this was a Terry stops in the 1960s. That essentially basically said, hey, they're walking down the street, they look suspicious, you have the latitude to stop them. It's not against the law. And since then, the bounds of what police can do and not get away with it has increased. So we're in now this era of police violence. And as we've moved through this era, we start to really consider the issue of police brutality. Police brutality is not just I use force, but at some point you can stop doing it and you will have prevented the behavior. So now we're not just saying I'm trying to control the behavior. At some point of time, it might just be glorious, right? You're involved in this act of violence for the sake of violence, right? So we have an issue around excessiveness. We have an issue around unlawful use of force. And we also have an issue on avoiding things that you don't need to do. So this is a conversation we're having now. All of the events that have been on the TV, these internet spaces, the question is always, when could they have stopped, right? When could they have stopped? George Floyd is a perfect example of this. They probably could have stopped 3 minutes in. It took them additional 5 minutes to stop. And in that 5 minutes, there was a loss of life. There was a loss of brain activity and something that couldn't be brought back. The conversation becomes that entire event of curbing his behavior, you didn't need to do all of that. So the conversation around police brutality is where we are today. And I'm pulling data from mostly New York City. We also pull another city and more generally some of the national stuff. We're looking at the policy of stop, question, and frisk. And this entire data set, the earliest time point for this data set is 2003. Before 2003, there was no systematic collection of data on police's encounters with pedestrians on the street of New York. And the street of New York, that is New York. It's always about the street. So we had no information. There was estimates. There was a general community attitude. And in 1999, there was an event where Amadou Diallo was shot for 41 times, walking out of his apartment building. And what happened that day is what eventually led to a lawsuit wherein we had to question, quite literally, was this policy, not the act, but the policy itself wasn't discriminatory. Well, we didn't have data at this time. So what they did then is they institutionalized, they mandated the New York Police Department to collect data. And this data set is New York Police Department Stop Question and Frisk database. It's publicly available. They have to release it every year. This was part of the mandate. That was in 2003, so it's 10 years before we actually see the policy itself be deemed unconstitutional. And the data that we're going to talk about within this context today is that interim period from 2003 to 2013. And the conversations that are happening on the ground there. What we know in New York City, when we look at neighborhood data, there are about 30 stops per 100 residents. So every 3 persons that within a group coming from a restaurant, one of them could be stopped by the police. Among those that are stopped, about 54% of those stops involve some kind of pat down, very light touching, just to see whether someone has something that could be of threat to the public or a threat to the police. And then in the same amount of stops, about a fifth of them involve the use of force. The use of force, it is aggressive. It's not just a pat down, it's the pushing of a body, it's the use of handcuffs in an excessive way. Like you would think about putting handcuffs on it, but then tightening it. Right, so the person say, hey, that hurts, but tightening. I mean, did you need to tighten it? That was a little extra in there. It's throwing the person against the fence. It's tasers, it's body, it's a body cameras, these types of things. So we have a question here about what's actually going on during the stop. Right. And what I found in the research is that it's not about the stop itself. We need to reduce the load of stop, question, and frisk, because once you get into an environment where stopping is considered expected, new norms come about. This is a sociologist in me. The environment itself becomes another person. And it's a person that's as close to you as your cat, your dog, your brother, your sister, your child, and your best friend. It's just right along with you. Among those stops, there are severe racial disparities in who and what happens and who gets stopped. Among those who are stopped, Black and brown pedestrians of the New York City environment are 6 times more likely to be stopped in general. They're 25% times more so than their white counterparts to be frisked, and they're 28% more likely than their white counterparts to have force used against them. So again, you can think about this all as relative. Instead of 45, 54% or 30% here, it's 36%. Instead of 54%, add another 15 percentage points. So everything is relative to each other. And what we're studying here is the impact of that additional thing that's happening. Assuming it happens.
I'm sorry, could I just ask a clarification for the slides on the right? So, because it says percent of stops that involve frisking, you mean, is this really the relative risk?
Yeah, this is relative risk. Yeah, this is relative. So here, when I say the racial gap is the 1.25, the bottom is the actual measure that we're using. So we're comparing the percent of stops for Black and brown to the percent of stops for whites. So that percentage is 25% more likely to happen for Black and brown pedestrians. Does that answer the question?
Yes.
Okay, great. All right, so what we find in the research is that if you look at the basic practice of frisking, so we're not looking at racial disparities here, we're just looking at that 54% increase in having a stop involved with pat down. We're looking at here we're looking at about the 25, the fifth of those stops involved some use of force. What we know is when essentially there's a standard deviation increase, and what that about means is about a 9 to 10% increase in frisking and use of force. So 54% becomes 63%, 20% can become about 30%. You have an increase in the odds of clinical distress, nervousness, hopelessness, and worthlessness. In particular, you have a 12% increase in clinical distress in neighborhoods where you get that 63% in frisk. You have a 16% increase in nervousness and a 16% increase in worthlessness. On the other hand, and so unfortunately, probably even more, I would say strongly the relationship is, and I would say this is really again a relative rate. Here you see a 21% increase when use of force is more likely to be used in the neighborhood for clinical distress, 14% for nervousness, 21% for hopelessness, and 18% for worthlessness. Now this is for everybody in the neighborhood, right? So it doesn't matter if you're Black, white, brown, woman, man, upper class, lower class, if you have a house or don't have a house, this risk is for you too, right? So we first off get this idea, not only that these stops that are happening to the larger public in this shared space matter, but also it doesn't matter who you are within these spaces. It's essentially a contextual neighborhood effect is what we call them. Now, if we actually do compare people in places by gender, we actually can look at within a neighborhood whether men are more likely than women to experience increase in distress along, and we're going to focus here on use of force, although you see very similar relationships with frisking. You see that among men are 21% more likely than women in these neighborhoods where there's an increase in use of force to exhibit indicators or feelings of that suggest clinical levels of non-specific psychological stress. 14% increase in saying I feel nervous, 12% increase in saying everything right now, it takes, if I want to go to the grocery store, if I want to, play out my friends, it takes a lot of effort just to start the activity, and 18% more likely to say I feel worthless. Now we can look at the numbers and maybe the numbers are right or they mean something to you or not. But what I think about is a boy who gets up from ready to go to school, and he's just like every other boy. There's nothing wrong with him. There's nothing right with him. There's nothing special about him. And he has to take those 10 blocks to go to school. And when he shows up at school, and he's, unfortunately, sometimes we're looking at these distressed neighborhoods where there's a hyper surveillance structure overall. One way you see it is metal detectors. So as he's going through this medical detector, he's having a little bit more palpitation. He's nervous, right? When he sits in that classroom, he's trying to figure out what 1 + 1 equals 2 times 2. And these are fairly basic things for us, but for him, it feels like there's a lot of effort. And in the end, he just doesn't feel like he matters. He doesn't feel like his perspective matters, his feelings matters. And so what's going to happen to that boy? He's going to eventually check out. Now we're going to look at that boy and say he has a problem, but in fact, whatever problems he's experiencing is a function or a reflection of the larger organizational the dynamics of living in hyper-surveilled in hyperly surveilled areas. We can understand psychological stress. Again, the entire stress model of police contact, it drives through issues of anxiety and depression, and in some cases psychotic behavior. But maybe something that makes us a little more uncomfortable is this idea of underlying conditions. So these are chronic conditions. Some of these are behavioral kind of spaces, and some of them is just, I don't feel like, my health is really good. I think it's poor is fair. It's a very standard item that's included in almost any community health survey, and sometimes just in a social survey. People want to know, how do you feel about your life, your understandings of your life. We know that same measure is actually tied to earlier rates of mortality. People who say that their health is poor or fair, they live less. They have lower life expectancies across the board. This measure is also related to neighborhood frisking. So again, where you have that 9% increase in the likelihood that a person is frisked, that there's a 9% increase in the odds of saying that, you know what, my health is not that good. There's a 12% increase in odds in saying, are actually being diagnosed as diabetic, being diagnosed as high blood pressure, a little more stronger relationship, 17%. And within the last year, you've had some type of asthma episode. This could either be uncontrolled asthma or actually an asthma attack, where you actually see the effects of uncontrolled asthma. You're 14% more likely to have one of those asthma episodes. And maybe what's a little bit more disturbing is that there's 22% increase in obesity. So we often see obesity as the gateway to a whole bunch of other health problems. And obesity itself has some of the stronger associations with neighborhood frisking. All these are persistent effects of all the measures of use of force and frisking and proactive behavior, whether we're talking about racial differences or we're talking about just overall prevalence level. Neighborhood frisking is the most consistent indicator of health problems. You see it with psychological stress, you see it with underlying conditions. And if you've been paying attention to the pandemic, diabetes, high blood pressure, asthma, obesity is implicated here. They're all things that are part of the leading indicators that someone will die of COVID if they're infected. So these are what we now call vulnerable. They're vulnerable populations that they're marked by these underlying, mostly chronic conditions. And these are the things that are more likely to be associated or show up in communities where there's higher levels of frisking. We can also look at the racial differences within these neighborhoods. So again, everything I was just telling you about this is for everybody in the neighborhood, but there are key points of time among minorities, you saw before among men, where there's a slightly higher risk of having a health problem because you live in these neighborhoods or because you are reporting these things in these neighborhoods. The bigger sticker here is high blood pressure. Blacks and Latinos tend to have higher levels of blood pressure in specific types of neighborhoods. They're not the same types of neighborhoods, which opens up a list of questions that we really can't answer yet with the data that we have. But what we know is that in areas where there are more stops, where there's more frisking, where there's more use of force, Black and Latinos face a higher increase of saying that they've been diagnosed in the past year with high blood pressure. We also know that this is more likely to occur among Blacks who live in neighborhoods where there's larger racial disparities and frisking. The statistic on here, or the relationship here that is very surprising, is the Asian Pacific Islanders who live in neighborhoods where there's larger racial disparities and use of force. They say, I don't think my health feels very good. It's poor or fair. They ask the question, how would you say about your health in general? This is important because Asian Pacific Islanders report less chronic conditions, and they also are less likely to be stopped by the police at all. And when they're stopped, they're less likely to be frisked and have use of force against them. So this is a population that, for all intents and purposes, are least likely to be quote unquote affected by police violence, police brutality, except they are in a very different way. But still they are. So we start to get this idea that these vicarious effects, these indirect effects, don't just operate through living in places where these things are occurring, but even on individuals who have the least amount of contact with the police, right? Least amount of contact with the police, that these things also matter for them, particularly in relation to their health. I see quite a hand there. If someone could read the question, I might want to try to get to it. Can anyone see it?
Dr. Sewell, can you hear me?
Yes.
Hi, how are you? It's Erica Phillips. So the question about just the 2 slides back real quick was when you're defining neighborhood frisking, is this sort of a continuous variable? So as neighborhood frisking proportion goes up, so does diabetes versus high blood pressure versus obesity? Or do you, in your data set, when you've captured in New York City, are you using some sort of cutoff to define this neighborhood as a high frisk neighborhood versus a low frisk neighborhood? I was just trying to get a sense of how you're defining that.
Right. Well, we're looking at it's a standardized measure. So we're looking at the full the 5 boroughs of New York City. We're looking at the overall distribution of frisking, and we're looking at a standard deviation increase. So it's linear, but not really. The way in which you interpret it is not linear. It's a standard deviation increase over that, which is the mean for the population. There's a question about whether to do the typologies you're talking about. And the reason why there's a question is because there actually is a fairly strong correlation between frisking and use of force. In this paper in particular, we split it. So we never look at one conditional on the other. Because of these high correlations, it's, if I do the numbers, it's about 50% shared ranking of these two neighborhood surveillance structures. So what I would say, if I were interested in doing this, taking this a little bit step forward, would love to work with anyone on this, is to look at the typologies of high frisk, high force, high frisk, high force, and then they're low in both of them. Does that make sense?
Yes, definitely. Thank you.
So I'm sorry, can I also ask a question? This is Christopher Gonzalez. Just to contextualize this a little better, presumably there are a lot of reasons why certain areas are more policed than others, including just like targeting policing and for racism. When we kind of like discern these numbers, what are we controlling for in terms of like, are we controlling for neighborhood socioeconomic level, neighborhood ethnic density or racial density? What goes into these numbers?
Yes. It's a great question. So we do two different types of adjustments. I don't like to use the word control because it's really a statistical term, but we do different types of adjustments where we're comparing people who are fairly similar on different types of things. One type of adjustment is related to the different types of characteristics of people in the place. So they're poorer people in the place. There are people who are more likely to be single. There are people who are less likely to have children. They're younger, right? So all these things that would create a context in which police will be more interested in understanding what's going on with those people. So there's more policing. We make adjustments for all those things, the standard socioeconomic status here, some family structure issues. We also take in consideration healthcare characteristics, insurance, having a usual care of a doctor, of course, some of the more basic demographic stuff. So that's taken care of. So we're looking at two different places where people are fairly dissimilar. Then we also account for kind of exactly what you're getting at. We look at three different things. We look at the proportion of Black and Latinos in a neighborhood. We look at the proportion of families who are impoverished or below the family poverty line. And we also look at, it's the robbery rate. So this is not the probability that you feel victimized, but you essentially have reported victimization due to a robbery, assault. We can have a conversation about why, or you use those variables versus others, but essentially when you think about race, class, and crime, we're looking for I would say the weakest correlation among those. By having a weaker correlation, you're able to understand what each one of those things are doing. If they're strongly correlated, you can't pick apart the effect of racial concentration from class concentration, from criminal concentration, but we choose measures that have fairly moderate, I would say, correlations with each other. And they also have different effects on health in themselves, as well as the different types of diabetes. And because you just mentioned that, I will show you the next slide, which gets at some of this stuff we were talking about. One way to come into this conversation is just to look at the concentration of Black and brown people in a neighborhood. Here are the numbers and the theories about the fact that this is the Amadou Diallo case, in which essentially culminates in this unconstitutional ruling on stop, question, and frisk in 2013. The main thrust of the stop, question, and frisk discrimination case was not that police were going around and choosing the Black person here or there in any neighborhood. No, it was that, in fact, the reason why Black and brown people were showing up in these encounters more was because police were targeting Black and brown communities. By default, there are more Black and brown people in them, but because they were targeting the communities, this is the hotspot policing. This is following the crimes, following the theories about class and whatnot. That they were in fact dealing more with Black and brown people. So we pulled this apart a little bit, and we examined the correlation and there is, again, a moderate correlation between there being a higher concentration of minorities in the community and there being a higher rate of, or higher likelihood of use of force. And we examined how the probability of reporting an illness, and again, these are a couple of these different underlying conditions, how that increases or is aggravated by the connection between use of force. Right, so when you have a place where minorities are more likely to be, and there's more use of force, what does diabetes risk look like if you only had one or the other? And so what you're looking at here is from X to Y on both columns. That's the minority concentration effect. So again, the general effect here, again at the bottom is that the impact of use of force gets stronger. So the returns, the health returns, or the illness returns actually of use of force get stronger, the more an area is concentrated with minorities. So again, what we're looking at, we're comparing a neighborhood where there's more minorities, let's say raw here, but this neighborhood, let me make sure I'm following there it goes. Here, the dashed line, the dotted line, the solid line is a place where 20% of the pedestrians have use of force against them. And in here, at the dotted line all the way at the top, you actually see this is 11%. And it happens, what I'm saying is there's a stronger increase. So usually, if there's not a lot of use of force, right here, this is that line versus that line. So I'm sorry, I'm getting up here. So this is the dashed line, and then the strong line here, the dashed line here, and the strong line here. As you get into more minority communities, the impact of use of force gets stronger. So this is that, essentially the context is increasing or aggravating, not we can say that the use of force is the same. So the likelihood of having use of force is 20% the entire time. Well, here is 11% the entire time. It's 20% the entire time. So that's not changing, but the impact of those things are changing, right? So we actually see crossover effects, specifically with obesity. And here we see that essentially being a minority in areas where there's a lot of frisking, or a lot of use of force, it increases your likelihood of having diabetes. So again, we're talking about rate of change here. So we can look at this same measure of use of force and we look at the racial differences. We would expect maybe that this is the same, but let me just go in here and just maybe trouble this a little bit. In predominantly minority areas, there's less minorities, okay? So it is likelihood, and this is the argument around the unconstitutional effect of use of force, that everybody in those neighborhoods are suffering, right? And again, this is what's going on the right side. However, what we find is that the impact of racial differences in use of force, where essentially Black and brown pedestrians are targeted for use of force more so than their white counterparts. This is actually also, it has there's more illness returns, right? But in white neighborhoods, in predominantly white neighborhoods, again, let me follow there we go. In predominantly white neighborhoods. All right, so here the dash line represents a place where there's equality, right? Where everybody has a risk to get it from the police. Police are not making any type of differentiation by racial characteristic of the individuals. And there we go. In this dash line, there are areas where essentially Black and minority, Black and Latino pedestrians are 69% more likely to have force used against them than others. What you find here, the thing that we're the thing that we're controlling here, right, is just the fact there's this increase, right, in use of force. These are all 20%, 15% minorities in these areas. These are basically predominantly white areas. You can look at diabetes, you can look at obesity, you can look at high blood pressure, you can look at worse self-rated health. There's a higher risk of these health problems in neighborhoods where there's more use of force against minorities than where there is more equality across the racial groups. This is some of this conversation around adjustments versus vulnerabilities, right? So here we get a more vulnerable effect among Black and brown neighborhoods when there's just more use of force, right? So if we can take the use of, if we can equal out the use of force, we can say, let's just don't change it or reduce it a little bit. Black and brown people are going to be healthier. If you keep at these higher levels, the more and more those levels are higher, you're going to have health problems. Here, you get a different relationship. Here, the difference is they're being treated in different ways. Right, Black and brown people are more likely to have use of force against them. And this is actually the norm, right? The norm is 28% increase. So now you're looking at an area where it's 69%. It's almost a doubling, right? It's a little bit over the doubling of the risk of use of force. And in these neighborhoods, predominantly white neighborhoods, is diabetes, obesity, high blood pressure, self-rated health. I have done analysis, does this vary among Black and brown people within these neighborhoods, among white and brown people, white and Black people? It doesn't, right? So what we know is that this is, again, an organizational effect of being in these neighborhoods. We find that literally just being in these neighborhoods for 1 out of 5, essentially Black, white, 1 out of 5, or 4 out of 5 white people, you're gonna have higher levels of health problem. We're now in a situation, again, about we're actually beyond vicarious effects, because you may or may not know the person who's getting sick. You may or may not know the pedestrian themselves, and very likely in those areas, you don't know the pedestrian. They don't live there, but they're using the space. You're also have an illness return for living in a society, in an organizational place where police are surveilling Black and brown people more forcibly. This is not the stop rate. It happens generally, but that stop is more likely to have use of force. The way I think about this is through the lens of psychophysiological behaviors. We know from these studies that if you hear someone screaming, right? If you hear a baby cry, if you're someone, you're seeing a lot of violence and so forth, you're not involved in it, but you're looking at it, there is more brain activity, there's more physiological responses in the stress hormones, there's greater palpitations in the heart. And the suggestion here is when you have this happening over and over again, so now you're looking at minorities are more likely to have this happening over and over again than whites. It matters for you too. As a bystander to these issues, you're losing out on your health as well. Does that make sense? Maybe a little bit of an answer to your question. A study we recently released, we're looking now here, the 10 years, this is between 2003, 2012. We have a measure of legal intervention deaths. If you're a vital statistics kind of person, if you're a demographer, you know, the kind of person, frankly, if you just follow about who dies of things, legal intervention deaths represent when a medical examiner or a coroner says the police did it. They open up the body, they see all of these different injuries, and they're saying, well, there's no way you could have gotten an injury that would kill you, right, if the police hadn't interacted in your life. So literally, legal intervention deaths mean the officer was involved in legal action. They were involved with protecting the peace of the place, the people around them. If in that area, in those areas where there are 3 or more legal intervention deaths reported by medical examiners or coroners in 10 years, in a decade, right? You have higher rates of, it's essentially CVD, the factors that lead to cardiovascular disease. All residents in these neighborhoods have a higher risk of high blood pressure and obesity. If you look only among women across these different neighborhoods, when women are in neighborhoods where there's more legal intervention deaths, they face a higher risk of obesity. Again, this is a gateway to a whole host of chronic conditions. And when you compare men and women in these neighborhoods, so you're looking among these legally surveilled areas, is how I referenced them. You're comparing the risk of a health problem for men and the risk of a health problem for women. And in those areas, women actually indicate that they're in the trifecta for CVD risk. They have diabetes, heart disease, high blood pressure, and obesity. We can have a longer conversation about what that actually means at a visceral level or experiential level. But the fact that there's a relationship at all, the fact that there's these disparities within these contexts here, it reflects this, I would say, Jekyll and Hyde, or 2 faces of the coin for when we understand the gender aspect of use of force. Gender, 85% of stops of police are of men, right? And when these things are happening, particularly when they're dying, you can go to the public records on fatal encounters. There's not a one-to-one correlation between legal intervention deaths and fatal encounters, but it's strong enough. And it suggests that, you know, mostly these are Black and brown men that are being stopped. So when these things are happening, women are going through a type of a network marginalization because they're close to it. They're the ones that are involved in the caregiving that is pulled upon someone who's in bereavement. Not just your bereavement, it's something that everybody around you is going through. A lot of these times, and you'll see it, they have these kind of public displays of respect for someone who's died at the hands of the police. It's a public event. It's not just a personal event. And that's the kind of issue we're talking about. To wrap up this conversation, I hope we're somewhere near on time here. Yeah, we're around there. So what we know is that, let's say we have all these health problems. If you are someone who reports less good health, so you say my health is poor or fair. If you live in neighborhoods where there's a higher concentration of frisking by police, that you are less likely to indicate within the last year that you have gone to the emergency room. These are actually Poisson models. These are counts. So you have less predicted numbers of ER visits within the last year. Why this is important is because we would expect that maybe these people actually would need it more because they're sicker. Worse self-rated health, as I said before, there's an increase of likelihood of reporting self-rated health in high-risk neighborhoods. Maybe we want to use the word, there's a standard deviation increase in frisking in these neighborhoods. 9 percentage points increase in the odds of reporting worse self-rated health. And we say that those same people who are reporting poor self-rated health, they have over the probability that a stop involves frisking, they're actually less likely to say that they will go to the emergency room, that they have gone to the emergency room. So these individuals are more likely to get sick, and they're less likely to get help for the things that they're sick about. This is a very sobering kind of way of thinking about it. When you consider this, I call this the negative illness feedback. The thing that creates the illness also is the thing that leads your inability to deal with the illness. So it's a feedback, it's a negative feedback. And this is data out of Philadelphia, so we can start to have this conversation about whether this is really a local it may be local in the sense of urbanicity, but not local in the sense of generalization. So I end here. People kind of get, you know, a little weird about me when I say this, but policing is the blood of America. It's the thing that holds all the other things together. It's a surveillance structure. And when we think about the fact that these are neighborhoods that's happening, these are things that are a function of segregation. In those areas, we're going to have higher levels of mobilization against the police. And all of this is about life, the preservation of life. And the reason why I say policing is the blood of America, because depending upon the quality of policing, brutal policing, less brutal policing, discriminatory policing, proactive, whatever else it is, that's like nutrients, right? So it's not that the policing is bad, it's the type of policing, it's the type of things that we're putting into our body. And when it comes to brutal policing, that's like basically saying you have excessive fat, right? There's a lot of extra things in there that don't need to be there. The type of policing itself leaves a very bad taste in your mouth. There's a lot of salty foods and a lot of salt. This is the way I think about it. I think about policing in its ingredient form, not the fact that you're putting the food in your mouth, right? But it has an impact on its own characteristics as food has an impact on how your body works. And when we can have this conversation in things like COVID and other types of issues, when it comes to blood, when the blood stops, that's the loss of life. The blood doesn't go, you're dead. So when you have bad policing, brutal policing, aggressive policing, you're creating a situation where you're going to create in physiological environments where there's less blood flow, you're more likely to get clogs, and eventually you either stroke out, you have a heart attack. This is the long line of this piece. And this, again, this statement is very difficult for people to stomach. And I think the only reason it's difficult is because of how you think about those three terms, policing, blood of America. Depending what you think about those things, it doesn't matter if it's good, bad, or indifferent, it's gonna sit with you differently. You know, it's gonna say, okay, this is good, this is bad, or what can we do about it? Or there's nothing we can do about it. And I think that's the conversation we're all here to have today. And this is my last slide, so we can go ahead and open this for conversation.
Wow, it was an amazing presentation. You know, I'm Canadian and moved to the States in my late 20s. And I was in Los Angeles, and one day I was jogging through a parking structure on my way to my car, and a policeman stopped me, and he said, "Who are you and where are you going in such a hurry?" And I was a doctor, a resident at the hospital, and I said, "Oh, I'm a doctor. I'm a resident of the hospital," and I went to show him my pager, which I was wearing on my waist, and he said to me, he didn't do anything violent to me. He said, "You should never do that with a policeman." He said, "I thought you were going for your gun." And coming from Canada, it was just such a shock that, you know, of course, this is a country where a lot of people have guns and people are paranoid about things. And I mean, certainly you didn't talk. I mean, frisking is obviously one thing, but shooting with little or no or negative provocation is another thing that obviously goes on to some degree as well. I just wonder, is it something to do with the culture of police in America? Are there similar phenomena that have been found among the police in other countries that have mixed race and ethnic populations? What's your sense?
I think it is cultural. I mean, you have police everywhere. So, you know, why is the relationship here? Number one, I can't really answer that because we don't have the data, but we do have data about the quality and surveillance cultures of different police. I would say the one that I would probably be most closest to is Brazil. So Brazil is a very diverse country when it comes to ethno-racial composition. Is very diverse when it comes to color. It also has a fairly a brutal policing regime. And from what we know, at least and this is qualitative ethnographic work, that level of targeting happens more so in the slums in these ethno-racially concentrated places, particularly in areas where there are a number of Afro-descendant individuals. And it's a very difficult conversation to have without numbers, but it's not a difficult conversation to have regarding the history of policing in these places. It's considered discriminatory, it's considered very targeted, and it's considered inequitable. And that's the conversation we're having. We do have a little bit of conversation around the type of violence with the lethally surveilled violence. A lot of this, there are gunshots. They are gunshots. Again, we need better data on this that is released publicly. But again, this is the moment of time when we're making that press.
Dr. Sewell, it's Erica Phillips again. Thank you again for that dynamic talk. The first time I had the pleasure of hearing you talk and recognizing something that I did not even realize how much was public data or in the public realm was when you gave the talk at Cornell 2 years ago in the Deep Wounds event hosted by the Cornell Center for Inequality, and I was one of the other speakers. Along those lines, obviously this, even though sometimes we as New Yorkers are hard on our city still does sort of lead the path in certain things that it does. And I really think that one of the policy things that came out of the Dulala case was obviously the release of this data. Do you know at this time how many other cities have publicly been forced to release their stop and frisk or police brutality data? And I think as a center, as we think about things that we should be advocating for, I think that this stuff needs to be more in the public realm, and New York has set that path. And so I'd be interested in seeing, have you been able to look at any other cities as this relates to it in the correlation of health and the use of extra force by police, or is it mostly because the data hasn't been released?
Yes, the data has been released, but two things. One, the data set that, again, mandated to be released is different than when people choose to release it, is Philadelphia. Philadelphia has a very different legal history around what to do with it. On one hand, you have a mayor that's a little bit more willing to take the kind of legislative pitch here, but you also have a very similarly brutal and inequitable police force. So we do have, it's called the Philadelphia Pedestrian and Vehicle Investigation Data Study. There are two differences. Number one is not just pedestrians, it's also drivers, but they don't have a measure of use of force. They only have a frisking concentration measure, which is what we use. That's the last study. The last study comes from that data set. In general, however, police records are supposed to be public. So you can go and ask the police department to give you data, but they may not give you all the data. So the difference between New York and Philly and other places is the standardized number one collection of data that is made public, right? So even the use of a UF-250, that's not standardized across jurisdictions. What people have done on the back end is they've backtracked it. So one is 311 calls looking for people who call in about a problem. And it's not a 911 call, it's just I'm looking for information, but the police respond. So you can track some of that here. We also have, I think Chicago, there's been some efforts to pull some of this data. Chicago has pretty good data on gunshot victims and what police does. Philadelphia does as well. It's a different kind of data though. What you're talking about is contact data, and we just don't have that. And even not at a national level, everything is perceptions. We have national surveys, perceptions of this stuff. Most of that they don't have geocode, so you wouldn't even be able to do what we're doing here, which is to back end it into other data sources.
This is Martin again. It would be interesting now that more departments are requiring videotaping of encounters with the police, that if it becomes possible to get a database of those encounters, one could actually evaluate and quantify the level of violence that occurs in the encounter.
Yeah, we call that systematic observation, but you're right. Yes, you're right. There are some conversations I've had. I know Chicago it's called a Project of Human Development in Chicago neighborhoods. They did have a systematic social observation. It's very expensive to get this data. Not one is getting it, but actually coding it and examine it. It's very expensive to do that. But I do think the conversation on body cams will open up a line of action for this next generation of scholars coming about.
Mm-hmm.
Hi, thank you for talking with us. My name is Susanna Morales. I feel like because of cell phones and the news, et cetera, and the internet, we're in a new phase where everyone no matter what neighborhood you live in, is traumatized by police violence. So it's an interesting thing to, sorting it out of, the personal or known contacts exposure to police violence versus every single person, practically in America has seen police murder on TV like 100 times. And so the impact that has, I mean, it's a very interesting and terrible thing to have to study, obviously. What is the impact? People have been talking about, I find my kid under the covers watching George Floyd get murdered. What is the impact of that televised trauma on people and the exposure? It's mental health and obviously we know that obviously the mental health and trauma translate to physical health, but it's a very important, interesting, difficult thing, I think, to sort out. But I do feel like we're in another phase now, because now there's a different level of documentation.
Yes, yes. So everything you said is true. And so let me parse it out to something where it may be a place to consider regarding how we train people. So at the end of this, I think the real differences are whether it mobilizes people or not. People have been traumatized on many things. And when we consider this from a health perspective, traumatization can bury you, or it puts you in spaces where you may try to change your environment. And so mobilization is that, I'm referring to here.
That's what we're seeing.
Political mobilization, exactly. You don't have, I'm calling it the 2020 uprisings. You don't have this across the globe. It wasn't in New York. It wasn't in Milwaukee. It wasn't in, Madison. It wasn't anywhere. It was everywhere. And some people saw that as, it was idiosyncratic. It was just sporadic. It wasn't sporadic. It was strategic. There have been people on the ground for decades, number one, but particularly within the last, I would say 10 years, that they've been thinking about how to get people to pay attention when people see things, right? Because we do have these videos. One of the first surveys I am aware of where people documented whether you recorded the police when they were behaving in misconduct was in 2010. It was a social justice sexuality project, and there's some preliminary research there. There's another national study that fielded the question, collaborative multiracial political survey. Both of them suggest that when people who record, people who turn on the camera essentially, they have better health, right? Especially when they've had prior contact with the police. So there is, one of this issue is that boy laying under the covers and he's seeing it happen. But what does he do about it? Does he continue to stay under the covers? Does he not leave? Does he cry about it? I would say he does all of that. And then he also can get into a club and say, what can we do about it? And the video cameras that you're seeing about the day, there are a lot of different videos that are going on. Yes, it's also the misconduct that we're seeing. There's a lot of videos out there about what people are doing on the streets to counteract that. This is going to end up being a question about mobilization. Yes, it's a conversation about trauma. Anyone who works with healthcare workers, social workers, nurse, psychologists know that when you deal with trauma on a regular basis like that, it affects you at a psychosocial level, physical, everything else. And so there's a cost to caring, right? There's a cost to caring. I think if this becomes a condition that we all are living in, the cost of caring can be distributed more equitably and equally. So it's not the organizer's cost of caring, it's all of us cost of caring. And so I would say, again, the baseline changes, right? So the baseline today, it is not the baseline from 2005. It's not the baseline from Trayvon Martin. It was a different baseline, but we call that in statistical models discontinuous effects, discontinuous slopes of what you're talking about. Before, when you saw this, incremental differences. Now we have all of this action. It can go here or it can go way here. It can be more effective in generating change, or it's like, A, happens all the time. We tend to, as a society, assume that the norm is the norm and not do anything to change the norm, right? So again, the question is about mobilization, which is about changing the norm.
So this is Monica Safford. I want to really thank you for a very stimulating set of analyses. You know, we sort of live in this very distressing era where science and well-done analyses don't sway a lot of policy and don't sway a lot of citizens' thinking. So, you know, you're from a different discipline than most of us. We're physicians, we're physician scientists, we're physician clinicians, we take care of patients. And we get very distressed when we learn of new things that impact our patients' health. And I think my sense, especially in our institution, since the George Floyd killing in May, there has been a huge amount of activity to try to self-reflect, find hidden institutionalized policies that contribute to racism. But what I hear as the division chief of general internal medicine and as the co-director of our Center for Health Equity, I hear a lot of people asking about advocacy and how to be more effective advocates. Yeah. And I know that this is sort of a scientific talk, but one of the things that comes to the fore is that we haven't been effective advocates. We have published a lot of papers, and many of them don't have the kind of impact that they potentially could. Can you just give us your personal and professional advice about what we as scientists and physicians could do to advocate better on behalf of our patients? Because you have a huge willing audience, but I think we lack the skills.
Yes, yes. So, you know, I agree completely. When it comes to the helping professions, we're here to help. A lot of us actually understands that we're servants, right? We're servants. We're servants and advocates for our people. So let's just kind of get a little bit into a little bit. So I think about a woman who is going 10 blocks. She has a doctor's appointment. She comes out early. She knows how long it takes her to get there. It takes about 20, 25 minutes. And along those 10 blocks, one out of, you know, 5 of those blocks, she's going to see a frisking. That's the numbers that we see in the data on average. And you can take that same woman and put her in a different neighborhood. Let's put her in a neighborhood in Minneapolis where some of this stuff is more likely to occur. And in an additional block, she sees the same thing. She sees the frisking that happens. When she shows up to the doctor's office, it is likely that when that doctor reads out her chart, he's going to see diabetes, asthma, high blood pressure. They're going to say, hey, you know, your BMI is considered not overweight, obese. We need to put you in a program. What that doctor doesn't know that he should know is that that person saw 1 extra block and that they've been seeing that extra block for a really long time. And the intervention point there is not, you know, eating less fatty foods, right? It becomes a part of system change, and it's not the system change in healthcare. It is an institutional, we call it systemic, means across institutional. Some of us in NIH, whatever we call it, transdisciplinary, pick your term for it, but it is going across the institutional lenses and having conversations with these different actors, not one-on-one, but at a policy level. So it is true that in these hospitals, the emergency room is probably the friendliest place for a police, because he needs to go to the emergency room to find out if there's someone who fits the description. On the other hand, the doctors want people to come to the emergency room when they have a gunshot. They don't want them dying on the street. So there's an encouragement there. So in that emergency room, there's probably a closer relationship between the police and healthcare professionals than any other part of the hospital. It's at that place where we can make a policy change, right? What happens in the emergency room? How is that doctor in the emergency room supported by other aspects of other divisions within the hospital setting, so that person doesn't become a body on a bed in a room, right, trying to get away from the police because they know that if they get caught or in the system, they're not getting out of it. It also is that the question I said about this woman who is not going to go to the emergency room, that shouldn't be the case. That person should be willing to go get help, the help that they need. So it is a conversation of community and the healthcare system. It's a conversation. I do believe this is healthcare to other institutions. You are advocates, yes. You come in with a health seeking behavior, yet, and other people do too. Police aren't police because they want to brutalize people. They're trying to protect the public, but the way that they're going about their job puts everybody at risk, including the people who are not in the hospital, right? And you who live in a really nice neighborhood in a great part of town, it affects you too, right? And it shouldn't. And so this is a burden, a societal burden issue, but I think it's conversations. I'm gonna throw this one at you. We spend tons of times in these administrative conversations about how we can reduce the cost for this and increase the cost for that. We do not spend the amount of time thinking about the role of police in the hospital in the first place. So if we took that, let's say 20% of that energy and put it there, y'all are smart people. You've been in school for a very long time. You might be able to come up with some new stuff that not even I know about, because everything we're talking about right now is based off of our prior understandings of our society, and we're looking for a new way. So I'm just understanding that if you all got together and started hashing this out and you cared and you put not institutions and money first, but put people's hearts, their lungs and everything else first, and understand that there's this connection that we're not catching. There's a symptom there that's not on the checklist. There's a diagnosis that we can have that's not there. And start to change the filtration systems, right, by which we deliver care and provide for these resources that we need. Pay the people who are saving those bodies more. The nurses, the social workers, the behavioral health psychologists, they're working and they're saving lives, and they don't get the funding that they need as someone who will go into a heart and look into a needle and figure it out. And they need to do that too, but we also need these equitable distributions of resources based off of the need of the community in which people are in.
Would you say then that if problems are systemic and involve things like the strategies and the culture of policing and other things, that interventions in communities to improve health in a community that just focus upon the health behavior but don't deal with the systemic epiphenomena are more or less doomed to fail?
They are, and I give my 4 pillars is where you live, is how you use the resources, the assets. You have people don't like to talk about it as assets, but it is that free money in a checking account at the end of the month, and you're like, hey, maybe I should go to a movie, or maybe you should maybe help someone who needs the help, who could use that extra $10 you would put in the movie. And it's also about this issue of what we call this policy, right? These are policy issues. We have to get engaged at this level, and not every 4 years or every 2 years, and think that your vote matters. It does matter, but your conversation with these people who are supposed to be making policies for you, who are leaders in thinking about how to construct laws and legislations that are going to not have feedback loops so that people can escape their responsibility, it's conversations with them. And I think this, when I say systemic, people throwing out a road systemic racism, no one knows what it means. It means that when you put, you have a soccer ball and you remove, for instance, one piece of it, it will grow back into something different. That's what it means. So why are we talking about this cause and that cause? Maybe we should just tear down the entire soccer ball. That hurts for some people, because they like the world they're in and they understand it. And to think about a different world, it causes anxiety. It causes me anxiety, right? And so what we do instead is we start to think about, okay, let's pull off the leather here. Let's change the density of the fabric here. Maybe we create a different type of nucleus when we're building these balls. It's one-on-one, but it's all of it going into it. And when you consider the professional aspect of this, that people have been trained their entire lives to do what they're doing, if we consider that one of these things we do, right, is protect people from criminal systems that are brutal and inequitable, we're going to get a lot more eyes on this, and you're all very, very smart, and we will get somewhere different than where we are today. I know we're at the end of time. I don't want to keep y'all, but I do appreciate being here.
This is wonderful and wonderfully provocative. So I think you're saying that notwithstanding the many decades of Band-Aids, Band-Aids aren't going to do it, huh?
Yeah. Well, you think about that, a soccer ball, you put too many Band-Aids on it, it cannot hold up the structure. I love basketball, baseball, anything with a ball, but these balls, eventually you'd put the wrong kind of protective casing and they're going to fall apart. And that's what we've been doing.
I think did someone else have a point? If not, I think our time is up. It's been a great talk. We can go on into the evening with this. But thank you for stimulating us and challenging us and encouraging us to do things that are substantial.
Thank you so much. Thank you for inviting me in. It's been awesome.
Okay then.
Bravo. Thank you.
Take care. Thank you so much.
Bye.